of Chandigarh in the cuisines. Without any further ado, I would like to extend heartfelt invitation to the chairpersons. Please come forward and lead us into this engaging, insightful session. I'm honored to invite Dr. Mary Ranela ma'am, Dr. S.P. Mishra sir, Dr. Pankaj Malhotra sir, and Dr. Prasoon Jalal sir.
Lunch, we have thin attendance, so I count the brains rather than the heads. So may I invite Massimo to deliver his lecture, What is New in EASL 2025, reference to primary liver tumors. Massimo?
Okay, no. I think we need some other slides. Yes, that one. Thank you. Good afternoon to everybody. Thank you for the invitation. On behalf of EASL, I will present you the best of EASL in the setting of primary liver tumors in 2025. I wish we can discuss later on the data and how they can be useful in India. These are my conflict of interests. During the meeting, there were a lot of moments where we can discuss about primary liver tumors, both cholangiocarcinoma and hepatocellular carcinoma, starting from a pre-meeting consensus conference on trial design and endpoints in the setting of ACC. We have to meet the experts that are generally very useful for young investigators, and many other occasions and symposium in co-work with other organizations. And finally, we have the 3 poster tours and 2 abstract sessions from where I took my abstracts to be presented. If we look at the presentation that I'm going to do, I think there is a fil rouge among the 8 abstracts. The first point is risk stratification for both diagnosis and prognosis, new treatment approach that not always means that are new treatment at all, but a new approach with all the treatment eventually. And finally, the role of basic science to guide the future direction, particularly in the setting of immuno-oncology. Machine learning, advanced imaging, and biomarker models are very relevant in all the abstracts that have been presented during the meeting. But I think 2 other aspects are the collaborative network that is the base to have relevant papers nowadays published, and finally a new vision. And I think the last paper that I'm going to present you is the perfect exemplification of a new vision in hepatocellular carcinoma. These are the abstracts that I'm going to present to you. The first one is novel 3-in-1 blood metabolomic test for the early diagnosis and risk stratification of primary sclerosing cholangitis and cholangiocarcinoma. The second one is the development and external validation of preoperative prediction model for early recurrence of intrahepatic cholangio. And finally, among the aspect of clinical aspects, the machine learning approaches for hepatocellular carcinoma risk stratification across various etiology. A very beautiful paper published, presented by the French colleagues. Then we move to therapy. The first one is the outcome by liver function in patients with unresectable hepatocellular carcinoma treated with nivo plus ipilimumab versus levantinib or sorafenib. The result of the CheckMate 9DW trial, phase 3 trial. then an holistic approach of systematic tumor and non-tumor biopsy during percutaneous radiofrequency ablation for hepatocellular carcinoma, diagnostic, prognostic, and therapeutic impact, and then deep learning derived radiomics with advanced machine learning outperforms clinical biomarkers in predicting the outcomes after atezo plus beva for advanced HCC. Then a paper presented by the nurses from England that is the demonstration of the success of a nurse-led service for surveying for hepatocellular carcinoma and other cirrhosis complications. And finally, the late breaker, liver transplantation after downstaging of both intermediate and advanced ACC with atezo plus beva, a prospective study that Dr. Sherry Burry presented during the EASL meeting, the Immuno-XXL trial. Let's move to clinical aspect except therapy, and this is the first paper. We all know that PSC is a chronic cholestatic disease that confers high risk of developing cholangiocarcinoma, and up to 20% of our patients with PSC will develop cholangio during their lifetime. However, the current diagnostic modalities for early detection of PSC and cholangio are suboptimal, and we need new predictive diagnostic non-invasive approach. And the aim of this huge effort performed by 13 centers in 80 countries worldwide was to investigate a serum metabolite biomarkers for PSC and PSC cholangio. They selected different populations. The first one is patient with PSC but without cholangiocarcinoma. Then a small group of patients who developed cholangio, but the serum sample was taken before cholangio development. Then almost 100 patients with cholangiocarcinoma already developed in the setting of PSC. And finally, two control groups. The first one is patients with ulcerative colitis and healthy individuals. They performed a very complex tests to identify metabolomics aspects, biomarkers, and they identified 3 different models that I'm going to show you, and then they use machine learning approach to generate the best diagnostic and predictive algorithms. The first one is the 13 metabolite model to distinguish PSC patients from healthy control with a very beautiful area under the curve of 0.98, both in the discovery and the validation cohorts. Then a second 13 metabolite models to detect patients with PSC who developed cholangio during their lifetime, and they compare them to a group of patients with PSC who did not develop cholangio. Again, a very beautiful under the curve of 0.91, both for the discovery and the validation curve. And this is very important. They identify patients at early stage of detection of cholangio. This is, I think, very relevant considering the expected survival of patients who develop cholangiocarcinoma nowadays. And this 13 metabolite model outperforms CA1999 both in patients with positive biomarker and in negative one. And finally, the third model is a 6 metabolite model to predict cholangio development in PSC. Again, the positive predictive values is good, 83%, both in the discovery and 73% in the validation cohort. And this model was able to discover and to identify those patients as early as 8 years before the clinical diagnosis. In conclusion, I think this was at least in the setting of primary liver tumor, one of the most relevant paper that has been presented by Rodriguez and co-workers during the EASL meeting, showing that this 3-in-1 metabolomic test is a useful non-invasive tool that enables diagnosis of PSC, early cholangio detection in PSC setting, and finally a prediction of cholangio development in these patients. I think this is a very relevant papers. Then in the French group tried to design a new model using machine learning models to identify those patients, stratifying the risk of ACC development in large cohorts of patients. The first one is HCV cured with cirrhosis. The second one is HBV under treatment. And the third one is non-viral cirrhotic patients, mainly alcoholic and metabolic related disease. A large cohort of patients, and they try to identify new new model to predict the risk of developing and the stratification of patients, to identify those patients who deserve a more aggressive surveillance, eventually with MRI, as yesterday I told to you. They designed a fine-grained regression model and then a single tree model using machine learning models. With the first model, they were not able to stratify patients better than the already in use models like the fast track and the EMAP models. However, with the single tree approach using machine learning, they were able to generate A groups with different risk of ACC development. And particularly, I wish to show you here that age is in the two of the tree. Then they were able to identify patients with a total bilirubin level high, serum albumin low, and platelet count low, that can be at higher risk of developing ACC, or at without platelet count at risk here, or even patient with high bilirubin level with HCV cured who has still GGT high level that are higher risk of developing ACC. And finally, age plus GGT with a higher risk of developing ACC. This is a first way to design this kind of models. Then we have a development external validation of preoperative prediction model for early recurrence of intrahepatic cholangiocarcinoma. This is again a multi-center study with a huge number of patients, more than 300 patients enrolled, with patients that has a diagnosis of intrahepatic cholangiocarcinoma. They were resected. They have a negative CT scan 1 month apart, and they identify by logistic regression model those patients at higher risk, medium risk, and low risk of recurrence. This preoperative risk score put together clinical aspects and radiological aspects, and it was able to identify those patients at higher risk of developing recurrence after curative approach, outperforming the typical TNM staging system. I think this model gave some good news, even if it is not so strong as expected. Liver tumors therapy, a few words on Checkmate 9DW phase 3 trial. This is a randomized controlled trial comparing the results with the primary endpoint of overall survival in patients treated with Nivo plus EP. EP only for 4 cycles, anti-CL4, while Nivo for all the duration of the treatment anti-PD-L1, and it was compared to a cohort of patients treated with lenvatinib, the majority, more than 80% of patients, or sorafenib. We all know that the results of this study is positive. We have a median overall survival of patients treated with nivo plus ipi of 23, almost 24 months, compared of 20 months for patients treated with lenvatinib or sorafenib, with a good results of survival at 24 and 36 months, and a long follow-up that gives a strong result in terms of survival. We all know that we are somehow afraid from this part of the curve, but data will be presented in the full papers. During the meeting, Bruno Sangro and co-workers presented the data of an expanded pre-analysis evaluating the efficacy and the safety on the combination of nivo plus ipi in the setting of ALBI grade 1 and ALBI grade 2 or 3. I think you all know that ALBI system is a very simple system to identify those patients at higher risk of developing of decompensation, at risk of decompensation in patients with child PUG-A. It's, I think, very useful score. And the result of this study is, again, that independently on the ALBI grade, even in patients with ALBI grade 2 or 3, this means that patients with a more severe liver disease, the benefit in terms of overall survival is there for patients treated with nivo plus ipi compared to patients treated with the standard of care lenvatinib or sorafenib. This is, I think, is very relevant for our patients with ALBI grade 2 or 3. Obviously, the survival is low compared to ALBI1, but is greater compared to the control arm. There is no safety data, negative safety data, even in patients with ALBI grade 2 or 3, in terms of treatment-related adverse events, ALBI 2 or 3 compared to ALBI 1. They are almost the same, with no new data in terms, I would rather say, in terms of the risk of the compensation. This is, I think, the most relevant curve of this paper. They show that the risk of the compensation is lower. And so this is a very important information they gave to us in patients treated with nivo plus ipi compared to patients treated with the standard of care. This is, I think, very relevant in the management of our patients that has always, generally always, and the cirrhosis underlying the advanced hepatocellular carcinoma. Then we move to I think, a very interesting, a new approach. They call it a holistic approach. They decided to perform liver biopsy before, but during the same session of radiofrequency ablation in patients treated for hepatocellular carcinoma, to identify several aspects with very interesting results. And I'm going to show you. The first aspect is feasibility and safety. They say that the feasibility is there. There is no added risk performing a liver biopsy before during the same session doing the TIRM ablation, with a risk of bleeding of 2% and no delay of performing the curative treatment. Very interesting, the role of the biopsy, the value of the biopsy. The first aspect, that only in the 66% of patients we have the results. The tumor was there, the positive results. While it's very interesting to note that the majority of cases we confirm the radiological diagnosis of ACC, while we have these patients where the first diagnosis of ACC was transformed in a diagnosis of intrahepatic cholangiocarcinoma or in a combined cholangio-ACC. And this is, I think, very relevant because we all know that the prognosis of patients with intrahepatic cholangio or combined cholangio plus ACC is different compared to patients with hepatocellular carcinoma. Another aspect is the liver biopsy in terms of non-tumor value, and they thought all patients were cirrhotic, and the liver biopsy revealed that only 80% or almost all patients, 80% of patients, cirrhosis was confirmed. So again, there was a misclassification in 15% of cases. And finally, the histological subtypes, and particularly the macrotrabecular massive subtypes, somehow predict the risk of recurrence. So we can use liver biopsy also for predicting the risk of recurrence in a curative approach. Then we move to deep learning radiomics with advanced machine learning outperforming the clinical biomarkers in a patient treated with atezolizumab plus bevacizumab. This is a very interesting work in collaboration between two centers, one in England, the Imperial College Center, and another collaborative centers in France, in Paris, and they showed that developing this model, putting together machine learning with clinical data set plus a radiomic approach, we can design complex and multiple algorithms with multiple features, and we can then select the best of these models that can be used in clinical practice. And they show that integrating radiomics plus clinical data in a single model, the area under the curve is very good both in the trying set and in confirmative set. And this is very interesting because the two cohorts are somewhere different in terms of clinical characteristics at baseline. And these two models outperform both the BCLC staging system and the ALBI-grade in predicting the risk of progression and in predicting those patients with a higher risk of objective response compared to other models. I think this is, again, maybe probably we need to refine this kind of models in clinical practice, but this can be very interesting to identify those patients who deserve to continue treatment with the high cost drugs compared to those who may deserve second line or different approach. In this paper, we observe that patients completely managed by nurses in terms of identify those patients at risk of ACC developing and surveillance with ultrasound and with other aspects like endoscopy and other aspects. They were more successful in terms of compliance of their patients compared to patients that are generally managed by physicians. I think this is very interesting. Probably this is a model that in UK works very well. At least in Italy, we cannot use this kind of model, but I think in the future we can think that these patients, particularly those with HCV cure, can be managed by a nurse clinic. As far as for the late breaker, this is very interesting. I start with showing you the result of the paper published some years ago by Mazzaferro and co-workers on Lancet Oncology, the XXL trial, showing that in those patients that obtain a downstaging from an up to 7 criteria to a within Milan criteria with whatever radiological approach, they can obtain a beautiful and very strong curves in terms of overall survival compared to those patients who obtain a downstaging with the same grade but was not transplanted. This was, I think, a unique randomized control trial in the setting of liver transplantation for ACC. I think we cannot reply anymore this study. And the other aspect, very relevant, for example, with atezolizumab plus bevacizumab, is that we can obtain a very high level of objective response rate, which means patients that start with an advanced ACC and can obtain a complete response, or more frequently, a partial response. Putting together these two aspects, the XXL trial and the results with the radiological results with atezolizumab plus bevacizumab, I think we start thinking to use immunotherapy with or without radiological approach for downstaging before liver transplantation. And again, Mazzaferro group designed this beautiful trial with a small number of patients, 18 patients. This is not a randomized control trial. This is a proof of concept trial with only one approach, and they identify those patients who obtain a partial response after downstaging with any radiological approach plus atezolizumab plus bevacizumab, and they observe the response to liver transplant, both in terms of risk of rejection, which was the major point in terms of safety, and in terms of outcomes. And the results of the trial is under review now. The results is very interesting. The duration of atezolizumab plus bevacizumab before liver transplant was around 5 months. Washout period before liver transplant was around 55 days. They decided the cutoff should be of 40 days for safety reason. And the median follow-up after liver transplantation is now 16 months. The results is good. The pre-transplant immuno-related adverse events is 19%, which is in line compared to the results of the clinical trials. The risk of immune-related adverse events after liver transplant, and this means the risk of rejection, is quite high, 25%, with 4 acute rejection, which is higher compared to recent published papers, but these are all histological proven rejection, with one death due to rejection, late rejection after second liver transplant. The results are, I think, very interesting, very important as a proof of concept that we can use in patients that were not thought to be treated with liver transplantation. If we obtain radiological response, probably partial radiological response, we can use in the setting of clinical trials the approach of immune therapy. Thank you for your attention.
Thank you, Massimo. Please join us. May I now invite Dr. Ashish Kumar as the moderator to give his comments, and the panelists Sujya Shrish, Amit Mandot, Dr. Surendra Singh, Dr. Deepti Sharma, and Dr. Rohit Mehtani. We are 3 minutes behind schedule, please. So Amit, Ashish?
Thank you, Chairperson. At the outset, I would like to thank the organizers of INASL for inviting me here. So I've been given the task of discussing what is the relevance of all these abstracts which has been discussed by Dr. Massimo for our Indian clinicians, Indian hepatologists, and Indian clinical practice, as well as Indian research. So we have a panel of experts here as my panelists, Dr. Deepthi, Dr. Rohit, Dr. Surinder, and Dr. Amit. And we also have expert chairpersons. We can take their opinion as well. So since these, can I have my slides? So, yeah. So, since the abstracts have already been discussed in detail, so I would just briefly to remind you what was discussed, and then we'll go on to the questions which I have framed for our panelists. So, the first abstract was 3-in-1 blood metabolomic test for early diagnosis. So, basically, it was on primary sclerosing cholangitis and whether we can detect cholangiocarcinoma in them using metabolomic biomarkers. So this using some of these metabolic, they actually tested about 50 metabolomic biomarkers and found that some are able to detect cholangiocarcinoma, some are able to predict development of cholangiocarcinoma at a later date, and some can actually diagnose PSC. So basically, the summary of this study was that novel blood-based biomarkers, metabolomic biomarkers, can non-invasively diagnose PSC and detect early cholangiocarcinoma and predict future cancer risk, which is better than CA 19-9. So I would ask, Dr. Srijaya is not here, so I would ask Dr. Amit Mandot. PSC and cholangiocarcinoma are basically rare diseases in India. So do we see enough of these cases in India to justify development of similar biomarker-based test here or validation in India? What's your opinion?
Can we have his mic, please?
Is in India on the rise, and we see enough cases of PSC. And at times, diagnosis of PSC is a little difficult, especially if it is not involving the large ducts. So I feel that this kind of a test would definitely have relevance even in India, and I think the results which was shown in this abstract were fantastic. The area under the curve was almost more than zero 0.9 for diagnosis and early detection of cholangiocarcinoma. So definitely, and I think like we would be seeing over the last few years, more and more we are moving towards metabolomics. So we will have to develop endogenous techniques to study these, and because it's a simple non-invasive clinical blood sample, so I think this test would definitely be valid even for India, and it would help us diagnose these cases. Whether it would whether we would be able to develop our own metabolomic, and whether the technique will be easily available on a cheap rate to everyone for clinical practice is a different thing. But the science behind it is definitely going to stay.
Yeah, so this was my next question, which you already answered, that it's a high-end technology-based diagnosis. So in India, can it be used commonly? But we can use it in tertiary care centers, but whether it would be accessible to common people and tier 2 cities or tier 3 cities, that's a question.
Once it is commercially viable, I think it will, in the sense, we had some studies going on with IIT with our PhD student who was working on muscle related metabolomics. So it's possible. I think we will have to involve our technology institutes and develop these models for ourselves.
And the whether so, what do you see the future of metabolomic research? Can, for example, this study showed that it can predict cholangiocarcinoma as well as identify these patients. So, can we use similar metabolomic approach for other diseases? For example, we see lots of gallbladder cancers and also high risk NASH patients.
I'm sure, in the sense, again, no data on this right now, but I'm sure as I said, the science is definitely exciting behind this, with machine learning and with more and more metabolic markers. It's a combination, and I think it is definitely possible.
Any opinion from the
Can I
chairpersons?
butt in? So you, hello? So you mentioned about carcinoma of gallbladder.
Yes.
We have a triple IT, which is one of the best in the country, and they're doing something on smell. So we're getting patients with carcinoma of gallbladder, early carcinoma, and their relatives, which are high risk. And just by the breath, the smell, the computer will be able to detect early cancers. Probably that's a hypothesis. So we have to wait for some time.
Yeah,
So
that's
AI will
wonderful.
be here in a big way. And metabolomics, if the labs develop it, the labs are there. If the volume is there, it will become cheap.
So in India, we have a lot of carcinoma gallbladder, especially Indo-Gangetic plains. People have lots of gallstones, and then some of them go on to. So this could be a very good approach. Yeah, Mary.
Yeah, so just a quick comment. So with respect to the high-risk NASH patients, I do think that there's potentially a role for metabolomics because there's really a significant heterogeneity, even among patients with all the common risk factors. And there are some panels that are being developed that look fairly promising. So I do think it's an important and interesting adjunct. Yeah.
Yeah, at risk MASH. Yeah. Thank you. So the next abstract which was discussed was on machine learning approaches for HCC risk stratification. So they had this cohort of HCC patients from multiple centers. They had total more than 3,600 patients who were undergoing 6 monthly ultrasound follow-up, and they used machine learning model, single tree, random forest model. They had validation and cohort also, which was 1/3, and they found that the HCC risk was about 2.2% to 2.4%, and their machine learning model fared somewhat better than the traditional models. So basically, learning models help to identify hidden risks, high risk cirrhotic groups, but only with slightly advantage over the traditional risk scores. So, question to Dr. Surinder Singh and Dr. Rohit here. So, in India, HCC risk in cirrhosis patients. So, do we need India-specific machine learning models to predict this risk, or do you think our own risk factors for cirrhosis and then AFP and that suffices? And we have a rising population of mast cell related cirrhosis. What's your opinion?
Yes, sir. So when it comes to the machine learning model, we definitely need to develop our own models because, as you know, our country is a vast country and etiology varies across northern India, southern India, eastern India has different etiology. So not only we need to make our machine model, but they will be varying according to the geographical location of the patient also, because etiology will be varying, and because of that the data which will be feeding to the various machine learning models will also vary. Depending on that, different models will be validated. So definitely the need of the hour is to have a good data which can be fed into these various machine learning models, and so that we can generate a robust model which can accurately predict the risk stratification in such group of patients.
The other question is on resource, because these are again machine learning models require very good data. Actually, the kind of data you input, you'll get the
That's how
results.
ML works.
So
Yeah.
we need Indian
So
centric
do we
data.
have good database to start with?
So no, we need to build a good amount of prospective data that can be used to create a India specific machine learning model, and then only we can implement it in routine clinical practice. Another thing about this abstract was the ORAC probably was low because the gold standard was compared, HCC detection was based on ultrasound. So we know ultrasound itself has limited sensitivity, especially in obese MASH patients. So then we need to see that also the model with which we are comparing machine learning with. So that also has to be taken into account.
But Ashish, one thing is even the retrospective data can be used for ML. And second thing is we see a peculiar problem in this country that even with PVK and alpha fetoprotein and 6 month screening, in between they develop suddenly large hepatocellular carcinoma. So that's a peculiar problem in the country. So probably ML may help you there.
Yeah, so that's a very relevant point you raised. So, in India, there's a problem of actually adhering to surveillance. Many patients are not undergoing surveillance. And even those who are undergoing, we have
And
people
large tumors.
within 6 months, they have had ultrasound and AFP, which was normal, but big tumors have come up. So we need our own data, we need our own database, we need our own registries, and then we develop machine learning models for our own. Uh, I'll skip some of the questions, but what are the practical steps which are needed for similar? So obviously registry data, and we. So any opinion on that? Yeah.
So actually, we have a cancer registry which is ICMR based. But unfortunately, I think we don't have a separate registry for hepatocellular carcinoma. So if we are able to develop a separate registry for patient and have a pro forma which is INASL endorsed that we need to collect data in a particular format, so that there is a good data which has been kept in a proper format that can help us to develop good machine learning models so that they can be later utilized for HCC prediction in such high risk group of patients.
So I can make an announcement here that INASL had given me the task for starting a registry. So that work is almost complete. So we will soon be launching a
Even here,
registry.
if you have a general registry and it's digitalized, it's very easy to pick up the HCCs from there.
Yeah. So I'll go to the next with abstract, which was discussed, was pre-operative risk model for early recurrence of cholangiocarcinoma after treatment. So there is no pre-operative tool. So the recurrence is actually predicted based on the post-operative TNM staging after the resection. And so this abstract actually discussed that based on pre-operative tools like clinical as well as CT imaging features, they developed a model which helped in predicting early recurrence. So a simple pre-operative CT scan and clinical based risk score was developed to predict early recurrence in intrahepatic cholangiocarcinoma, and which was better than TNM staging. So again, question to Dr. Deepti. Intrahepatic cholangiocarcinoma in India often present late. So how often do we actually are able to resect intrahepatic cholangiocarcinoma in Indian practice? And how applicable would this model be in our surgical cohort? So any opinion?
So, sir, it's like so more than 50% of the patient present with metastasis at diagnosis. Further, 30%, about 30 to 40% present with advanced cholangiocarcinoma, which are inoperable at the baseline. So only about 10% of the patients are operable at the baseline. And like in ILBS, we are surgery has been done in about 12 to 15 patients per annum. So like for the clinical perspective, we can see like raised CA 19.9, multifocal disease, satellite lesions, involvement of lymph nodes, tumor size. So these are the few factors which are predictive for early recurrences. And yes, radiologically again, we can find out whether it's a heterogeneous tumor or not, which helps in to find out as a risk prediction for early recurrence. So I think that risk model should be done. We can do more prospective studies to validate this risk model from Indian cohorts.
Ashish, I
yeah.
wonder if the 13 metabolics could help here too. The
Yes, sir,
metabolic
we can
study
include
could,
the
Metabolomics
also.
mode
yes, metabolics could help here too.
can also help. So
Like we have done a study for TMOs.
uh-huh.
So we have finded the TMO levels in CA gallbladder patients, and then we have predicted the overall survival in such group of patients. And similarly, we have done the metabolites in HCC as well.
And so other questions are, do we have good radiologic infrastructure, especially so in the CT scans, especially in ILBS and other tertiary care centers are very good, but what we receive CT scan from other private
Yes,
centers,
it's
they are
These results are not consistent. So we need a better data set
Yeah,
to validate.
yeah. And could this model be used to decide on neoadjuvant therapy as well? Like, yeah.
Yes, sir. So depending on the tumor size, the lymph node involvement, the high raised CA 19.9 levels, CEA levels, one can plan for neoadjuvant therapy. There are papers by Yakashita et al. Which have demonstrated that if we treat the primary tumor early, it reduces the chances of cholangitis. So and also there's a reduction in the progression-free survival. So we can treat the patients with neoadjuvant therapy if there are satellite lesions high CA 19.9, followed by surgery. It will give an idea about the behavior of the tumor as well. Further, post surgery, we can find whether the margins are positive or not, if lymph nodes are involved or not, and extracapsular extension. Accordingly, we can plan for the adjuvant therapy as well, like radiation therapy and chemotherapy.
Yeah. So Dr. Deepthi is a radiation oncologist. So she has a lot of experience in all these tumors. One question, as a radiotherapist perspective, could high risk patients, for example, using this model, I mean, you already answered that combination therapy can be given. Coming to the next abstract, that is systematic tumor and non-tumor biopsy during while doing RFA. So this was a very good study. They used 248 patients, and while doing their RFA, they took biopsy from the tumor as well as from the adjacent non-tumor. And what they found that some of there was discordant result between the pre-operative pre-therapy and the post during the biopsy results were discordant, and also the diagnosis of cirrhosis could be achieved in some of these patients. So basically, systematic tumor and non-tumor biopsy during RFA for HCC is safe, and it improves diagnostic and prognostication and future molecular analysis. So how many of you are getting biopsies done during RFA? Can you raise hand? Very few. So Dr. Amit, biopsy is a very underutilized therapy during RFA. So do you believe that we should mandate our intervention radiologists to do biopsies during RFA?
I think so. In the sense, clearly, the hepatologist, because we have had the entire diagnosis has been based on LIRAD's staging, we have almost underutilized biopsy, and we are not getting much information even from the treatment point of view. So for all these years, we have equated morphology on imaging with biology of tumor, and I don't think it is so simplistic. I think the biology is a little more different than just what the morphology will tell us. So we need to use, if any patient goes directly to an oncologist and they treat, they will always biopsy. So I think we have to learn a little bit of oncology from them. Yes, we have always been worried about the side effects and risk of biopsy, but there are two situations where biopsy can definitely have a role. One is India being a center for mainly LDLT. Now, when we downstage the tumor, the waiting period in our system is usually 3 months. Both the study from Medanta on LRT related downstaging and from AIG, where they have used chemotherapy, immunotherapy related downstaging, they have had a waiting period of 3 months. Most Western studies based on DDLT would have a waiting period of 6 months. So for long, that waiting period has been a way to study the biology. But if we can biopsy, there are some centers like in Toronto where they biopsy routinely before a liver transplant, and based on the findings, the risk of recurrence. So that is one area where biopsy can be useful. Another is definitely with the lot of patients where we see mixed HCC cholangio-CA, and that is definitely, we are all seeing that routinely in clinical practice. We have had one patient post transplant turned out to be, so it's difficult. So I think when there is some discrepancy on imaging, we should biopsy, and in the living donor liver transplant, I think we can use biopsy a little more.
Yeah, Massimo, what's your experience? Are you doing biopsies during RFAs?
Well, We are increasing the number of biopsy we are doing in our patients compared to the past with non-invasive methods. However, generally we obtain the biopsy before in a separate moment because we think that we can decide the best option for the patients before. Otherwise, for example, in this study that has been published in UAG journal now, they have these patients that they discover to have intrahepatic cholangiocarcinoma, but how can I say, it's too late. Probably they can be better treated with surgical resection compared to radiofrequency ablation, but it's too late. If you have the biopsy some days before or 1 week before, you can decide to move from radiofrequency ablation to resection. The positive aspect is that the risk of bleeding, of complication, is lower compared to clinical practice because in the radiological setting they have all the device to stop bleeding easier than we can do in our clinics. This is, I think, the safety profile may be different.
Yeah, so you already answered the question about risk, biopsy risk, but on misclassifying HCC, because these patients, if they had intrahepatic cholangiocarcinoma, they could have been subjected to resection. And Dr. Amit, have you encountered any patients in whom biopsy actually changed in HCC? Biopsy actually changed
No, I think we should be used more, but it's just that we don't have the evidence, and most clinical guidelines won't allow you to do it. So we follow those evidence based, but I think we should use it more. So as a routine, we don't, but we have had one patient post transplant where we have had a mixed picture, which was not picked up on imaging. It was LIRAX 5 imaging. So clearly, that's one anecdotal case. But I think the only prominent feature in this study was that 34% patient had misdiagnosis, which is a little odd. So that's again an eye opener. Maybe we are also misdiagnosing a lot of them, but 35% patients being misdiagnosed on imaging was a bit odd.
So we need to cover more abstracts. So the next abstract is on radiomics and deep learning, which outperformed the clinical biomarkers after Atizobev. So this was 162 patients data who received Atizobev from 2 centers, and then they used radiomics as well as deep learning module, and it significantly outperformed LB score as well as BCLC score in predicting survival of Atizobev. So Dr. Deepti and Dr. Rohit, so how practical is the implementation of radiomics in current Indian oncology practice? And are our CT scans compatible with such?
I think we need to buy a separate software which can do the radiomics for us, but the PAC system is compatible. There are centers which are doing radiomics on the routine CTs.
And will you use that radiomics derived models to guide your treatment decision? And for example, if radiomics predict that Atizobev would not be beneficial, would you not give?
Yeah, so before implementing, we need good quality data on Indian patients.
On Indian patients.
So if that is available, then yes.
But why are you defensive about Indian radiologists? 34% were missed in that study. 1/3 were missed in the study of the RFA.
Yeah.
So don't blame Indian radiologists.
Indian patients.
Indian patients.
Indian patients.
Not radiologists.
Yeah.
And we need our own studies.
The model should be validated on Indian patients.
Yes, that's right.
Yeah.
It's the same as we need more validating the studies from India continent.
Okay. And the next abstract I would discuss was the nurse-led clinic improved HCC and cirrhosis surveillance adherence. So they had this wonderful study where the nurses were actually given the job of doing the surveillance, and then it was helped by hepatology assistant practitioner and one clinical consultant, and it led to a superior adherence to HCC surveillance protocol because of nurse following. So, Dr. Amit or Dr. Surendra, you can answer this. Do you see a such role of paramedics or nurse practitioners in India who can help in surveillance?
Definitely, sir, in high volume centers where the patient load is very high, we can have a use of clinical nurse specialists in ensuring that the patient show up for follow-up scans or their follow-up visits on time. So a limited role is there, but the role which has been shown in this study, I think we cannot replicate this because we do not have a structured training program for nursing officers in our country. So I think a limited role is there where we can ensure that patient comply to our advice. They show up for scans at scheduled time, but we cannot replicate this study as such in our setup because this is a study based in UK.
The law has to change. They should be allowed to do. No, I'm sorry. We are running short of time. If you have any pressing question, just one
Yes, I
minute.
have a quick question to actually Massimo. For the biopsy that you do separately without the RFA, the biopsy risk is not really from the bleeding or the complication, but what about the implant seeding and the tumor seeding into the peritoneum? I think that is the bigger risk we need to consider.
And that risk would also be for pre-transplant setting also as well. Yeah.
Well, yes, I think that probably the risk of seeding is linked only to patient after liver transplantation due to the immunosuppression. However, the risk is very low, less than 3%, and generally I would say that I'm not. I want not to be too sophisticated, but I would not say that is a metastatic disease, but is a seeding. Generally, very, very easy manageable by surgeons, and generally it does not convert to a metastatic disease. At least this is my experience and generally experience. And in terms of bleeding, I think that we are going to see a lower risk in patients without cirrhosis or with higher level of platelet and I think in the setting of muffled in particular.
I think we have got the.
So thank you.
Yeah.
I think we finish off with this. Thank you, Massimo. Thank you, Ashish, all the panelists, and my co-chair for this wonderful session. A big round of applause.
I have just one last announcement that INASL, in combination, in association with ILCA, is organizing joint INASL ILCA School of Liver Cancer on 19th and 20th December. I would like to invite everyone to you. It's on Friday, Saturday, Leela Ambience, Gurgaon. So save the dates and we'll send the details. Thank you.